Perfect. Yeah, so my name is Kaveh Gaynor-Sodeifi. I'm part of the Pulmonary Critical Care and Sleep Medicine Division. And I'm here to present a case just to kind of highlight an important thing to think about when seeing a patient and trying to determine a cause of sustained nocturnal hypoxemia. So we had a senior female who presented with sleep maintenance insomnia and daytime sleepiness. And review of all of the symptoms were relatively unremarkable or insignificant. And so we ordered a nocturnal polysomnography to kind of get a better sense of what was going on that might be causing this daytime sleepiness. We didn't see any frank obstruct or significant sleep apnea. What we did find was significant sustained nocturnal hypoxemia. So you can see here there are 2 bouts of very prolonged nocturnal hypoxemia, which was quite a remarkable finding and something we weren't expecting. We repeated with overnight oximetry and again confirmed that this nocturnal hypoxemia was in fact happening chronically. PFT function and CT chest did not find any significant pulmonary deficits or pulmonary disease, which may have explained this hypoxemia. So without that in mind, we were starting to try to think what could be causing this sustained nocturnal hypoxemia in someone who has a relatively normal BMI, has a normal SpO2 at rest, and has no pulmonary disease. So our line of thinking was maybe a PFO or some sort of shunt. And in fact, when we did an echocardiogram with a bubble study, we did see that in the setting of normal ventricular function and no pulmonary hypertension, we did see early opacification of the left chambers, which is indicative of intracardiac shunting. So this was sort of our working hypothesis. We then followed up with a cardiac catheterization and found that with sedation, her blood oxygen fell from 106 to 64 millimeters of mercury, and her SpO2 dropped from mid-90s to mid-80s with that deep sedation. So in fact, there was something going on with sleep that was causing this desaturation. We then ordered a closure of the PFO, and repeat nocturnal oximetry showed a complete correction of her overnight, or showed resolution of her hypoxemia. And so really what we wanted to sort of highlight with this study was, in the absence of frank pulmonary disease, perhaps obesity-related hypoventilation, that a PFO or a shunt should be considered as a potential cause of nocturnal hypoxemia. And with closure, you are able to correct it and fix that. Unfortunately, it didn't fix her main symptoms of sleep maintenance insomnia and daytime sleepiness, but we did correct her incidental observation of nocturnal hypoxemia.